to VerifiedRx, your prescription for success. Brought to you by the Vizient Center for Pharmacy Practice Excellence.
Traditional drug spending in the U.S. is outpacing specialty drug spending, and there's one major driver behind it, GLP-1s. From diabetes to obesity, incretin-based therapies are reshaping the clinical and economic landscape. On today's episode of the Center for Pharmacy Practice Excellence VerifiedRx, we're diving deep into the world of GLP-1s. I'm Stacy Lauderdale, and I'm joined today by my Vizient colleagues, Heather Pace, Senior Clinical Manager of Ambulatory Care, and Emily Fitt, SG2 consultant, for a wide-ranging conversation on everything from telehealth services to what truly sets these therapies apart. Tori Richie, Senior Consulting Director, Intelligence, will be your host. Heather and I are leading a national workgroup series alongside external experts to help shape a GLP-1 stewardship framework for obesity and its related conditions. And Emily, our go-to SME for medical and surgical weight management services at SG2, brings insight into how care models are evolving to meet the growing demand. Grab your coffee and settle in. This isn't just a discussion. It's a front row seat to how GLP-1s are redefining the future of healthcare.
And today we are having a meeting of the Vizient podcast minds. I am joined by podcast co-host for VerifiedRx, Stacy Lauderdale, and Heather Pace, a senior clinical manager for ambulatory services for the Center of Pharmacy Practice Excellence. And Stacy Lauderdale is an AVP of Evidence-Based Medicine for Vizient. Heather, Stacy, thrilled to have you on SG2 Perspectives today. I am also joined by SG2 expert Emily Fitt. Emily covers all topics under the medicine service line group, thinking about a wide range of service lines and conditions. The four of us today are going to dive deeper into the conversation around GLP-1s. This certainly is a topic of conversation that's had a lot of buzz in the media over the last 2 years or so. I would like to get your all's perspective. How do GLP-1 medications differ from traditional treatments? And why has there been a shift in focus from treating type 2 diabetes patients with these drugs to broader patient populations like those that are dealing with obesity?
I can start us off. I don't know that GLP-1s necessarily differ from traditional medications. What is different is that these medications are indicated for obesity, which is a chronic disease state. When you think about obesity management, it's not just pharmacotherapy alone. It's pharmacotherapy, but lifestyle interventions are the cornerstone of management of obesity. And then you have other tools like pharmacotherapy or even metabolic surgery. The reason why things are a little bit different is because we have to be very aware that pharmacotherapy is just one tool among many for obesity management.
I would agree with you, Stacy. When I think of obesity management, it really is a tool. And pharmacotherapy is just one tool that we have in our tool belt. Bariatric surgery is one tool that we have in our tool belt. Lifestyle modification is one tool. While GLP-1s are expanding that access to a new tool, we still have this whole toolkit of treatment options that we can use. When we're thinking about program growth for bariatric surgery or for medical weight loss, we really have to think about that overall comprehensive lens of having options, the right tool for the right patient at the right time.
The newer weight loss meds that we're seeing being used for obesity, there wasn't anything that achieved a similar percentage of weight loss like we've seen in bariatric surgery. So it's new. In patients that have bariatric surgery or some of those intensive interventions, it's high touch. But right now, we are not seeing that high touch with the GLP-1s in obesity, which is critical to the success and the safe use of it in obesity. There's not a lot of guidance out there. We do have the guidance in the bariatric space as far as diet, nutrition, but it's relatively new GLP-1s in the obesity space and how the patients respond differently, whether they may lose muscle mass or they may just have so much side effects that they're not eating. We're on the frontier of using these and we don't have a lot of information about them. We do recognize it really needs to be high touch with those patients. That's what makes them a little bit different in diabetes. The GLP-1 use for diabetes doesn't necessarily need to be as high touch as it is for obesity to manage the patient to use them safely.
And Heather, I'm wondering if we could expand on that a little bit related to what are those common side effects that the GLP-1 therapies cause, and how can clinicians effectively manage patients that might be experiencing those side effects?
Commonly, the side effects are gastrointestinal, GI, whether it be nausea, vomiting, it could be constipation or diarrhea. We tend to see them in the early phases of treatment, but they do continue. And so that's why it's important. A lot of patients just don't feel good when they start taking them. The doses have to be titrated, and almost every 30 days, they should be talking to a practitioner, but even more often if they're experiencing side effects with that. Patients on GLP-1s need to be intentional about what they're eating. It needs to be nutrient dense to be able to avoid some of the longer term side effects that could happen with these as far as losing muscle mass. It has to be a patient specific approach and an interaction with the practitioner just to know how the patient's feeling on them and making sure you're managing appropriately.
Emily, I feel like this is a conversation that we've had quite a bit on the SG2 side of the house about the importance of deploying a fully developed program that involves treating multiple aspects of patients' health when introducing individuals to these drugs. Could you expand a bit on what some of those strategies are, what some of those program offerings look like?
We've seen a couple newer things in the past year that may point to the need for a more comprehensive approach for these patients. We've seen some expanded indications and FDA approvals for these medications. Sleep apnea, for example, was an expanded indication. We've seen expanded indications for patients with type 2 diabetes and chronic kidney disease. We've seen expanded indications in 2023 for cardiovascular disease. So now we've got cardiologists, gastroenterologists, nephrologists, pulmonologists that could technically be prescribing these medications. And is that the right person? Is that the right quarterback of that patient's care? Oftentimes we're seeing these medications are prescribed in the primary care setting, first and foremost. We've seen systems ramp up their primary care workforce, have additional training for primary care providers in obesity. We call them obesity medicine diplomats. So they go through an additional training and board so they can become certified. So it's that ramping up of primary care. It's booking the primary care providers specifically for obesity visits. So filling that patient panel with a very specific condition. And then it's implementation of pharmacists. And Stacy, Heather, I'd like to know your thoughts on that. You're the experts here. What are you seeing, or what are some of your colleagues recommending on that?
Yeah, we actually right now at Vizient have an ongoing work group series of external subject matter experts. And many of these individuals that are joining our work group series have collaborative practice agreements where they're working to ensure appropriate titration of these medications, ensuring appropriate dietary intake of, say, protein. These pharmacists are important in ensuring that we're handling the side effects appropriately and we are achieving a patient-tolerated dose while maintaining an appropriate intake of nutrients, vitamins, and protein.
Some of the concern with the primary care is the access to your primary care physician. These are to be titrated until you can get to the maintenance dose every 30 days. And that's just not something that your primary care physician is not accessible, but a pharmacist would be to support that use in the primary care setting or whatever setting that's got to be high touch. We don't want someone starting a GLP-1 and discontinuing or getting lost because they were experiencing side effects, because we've seen that people just gain the weight right back when they discontinue. And so it's really important to keep that touch, keep a pulse on the patient and how they're progressing, particularly with side effects, and just making sure they're continuing to take that medication.
In addition to medication management and titration of the medication, what other challenges do providers face when integrating these drugs into practice?
There's been a lot of challenges with the shortages and access that providers can't impact, but shortages have resolved over the last year. If you have a patient that cannot get their GLP-1, they just can't access it and they can't continue that treatment. That's a challenge. We're starting to see that resolve. Coverage as well. A lot of the payers aren't covering these. They're not cheap. They're relatively expensive treatments if someone was self-pay. So I think those are challenges outside of what prescribers control, but they definitely impact a patient's ability to continue to take that medication.
The other thing is around care access. Certainly the programs that may filter people through an obesity clinic. the wait lists are long. What we're seeing is people going to telehealth services to be managed for weight loss. I'm sure that's a whole different discussion. That's another germane point is, can people access care due to wait lists?
We saw that the FDA recently announced that both semaglutide and tirzepatide are no longer in shortages, and they're going to start cracking down on compounding pharmacies. So we may see an influx of folks that were on a telehealth platform going into the health system saying, I lost coverage or I lost my compounded semaglutide. I want to see what my options are. We could see more of these telehealth platforms partner with pharmaceutical companies that directly make the drug. But I think we're going to see that price shift. It's going to get more expensive when we don't have the compounding options anymore. On the flip side, we're also seeing the price go down in semaglutide and tirzepatide. And I'm sure we'll continue to see price competition as more and more medications hit the market.
And it's interesting, Emily, I just read where Lilly has done a contract with a telehealth service to offer tirzepatide at a cheaper price. We will see different models pop up.
Are there any quality or outcomes concerns with individuals that opt to receive these drugs from one of the telehealth providers or a program that does not have the ability to be quite as hands-on as a traditional healthcare provider can be for these drugs?
To Heather's point, it's about high touch. These patients should be having visits or should be having multiple touch points with a provider. And with those telehealth platforms, it's so murky. You're supposed to meet with a provider before you're prescribed these medications. That's not always the case. You're supposed to follow up with the provider every so often to discuss titration. And with these telehealth platforms, it's the Wild West. So if you have symptoms or adverse events, the telehealth platform may be able to help some, but if you need to go in person to something, the health system is the one that's going to be taking on that increase of demand from symptom management.
I would love to see data sometime in the near future. There will be data, but right now I tend to think that Emily is probably correct. In the future, I think we will see data on what does a comparison look like between a telehealth weight management versus more your traditional clinic-based.
Well, and those are some of the solutions that are being offered to the payers that are choosing to cover these medications for obesity are these business models that we can help manage your patients. Generally, they're from a telehealth perspective. That's what they're taking to the payers to help them manage their patients that they are paying for obesity coverage for their medications.
It's interesting that we still don't have full access to these medications. We still have a lot of folks utilizing telehealth compounding platforms. We still have pushback from employers on GLP-1 coverage. But if you look at our Vizient spend management outlook, semaglutide is number 3 on the highest spend for self-administered medications, and tirzepatide is number 6. So they're already incredibly high spend medications, and we still have only provided access to a fraction of who could benefit from these medications.
Yeah, IQVIA has a report out. They suggest in the next 4 to 5 years that GLP-1s, in addition to oncology, will be the main drivers for prescription drug expenditures. And GLP-1 utilization will be driven by obesity and its related comorbidities, not diabetes. You're right. We've only seen the tip of the iceberg.
Given the growth that's in this space, I'm curious what other trends are facing this landscape? How do we perhaps see the GLP-1 therapy landscape evolving over the coming 5-10 years?
We're going to have more medications, so more access. We'll see price competition as more medications come out. There are over 140 medications in FDA clinical trials right now for GLP-1 medications. We're going to see different types of medications. We have pills for type 2 diabetes, but we'll see pills expanded indications for obesity. Stacy, Heather, any thoughts on different types of medications or combinations?
Right now we have GLP-1s, we have GLP-1s plus GIPs. In the future, we'll have plus amylin. There'll be triagonists. There'll be oral formulations. What I would like to see in the future is, while we know they may differ a little bit in weight loss, at the end of the day, it's not so much the weight loss as the clinical outcomes, the cardiovascular risk reduction, those sorts of things. And so do these agents differ in clinical outcome as well? Are some of them maybe better insulin sensitizers than others? I will be interested to see, because our pipeline's rich, do these start to even differentiate themselves more into different generations? So maybe we start off with GLP-1s and they lost about 50% of body weight. And then GLP-1s plus GIP-1s, even more weight loss, but maybe are better insulin sensitizers. And what does the third generation look like as a triagonist? And so that's what I'm really interested in seeing is, do they start to differentiate? And are there particular ones that start to become comorbidities, favored in particular?
Are there any best practices that providers should deploy as they think about building programmatic offerings that center around these drugs? We've touched a bit on ensuring that you have access, that you provide a high touch service to patients, but what else should providers be thinking about?
There's really not any best practices out there yet. And that's what we are working on with our focus group. Every institution, every program is going to have to make it meet the needs of their institution, but there's really not a lot out there that is outlining best practices just yet. We are on the forefront of it, and we will start seeing it as we get more experience in patients. And as coverage expands, more patients are going to be using it. We're going to have more patients to manage on this. We're going to have to figure out how to provide coverage and access for them. So there is a need for it. It's just not out there yet.
I agree with that. But one of the things that these agents, if you have class 3 obesity, you're probably not going to get to your goal weight loss on just one of these agents, even though they are the most effective weight loss agent we have right now from a pharmacotherapy perspective. And one of the things that we don't have a leading practice around is combination therapies. That is also something we're going to have to really think about in the future, or using this to get to bariatric surgery. And what do those different combinations look like? And we're very early in that learning process.
I wrote down the words effective, efficient, and scalable to how we're going to have to meet the needs of the population that could benefit from these medications. So effective, are patients meeting their goals on the treatment? This could be weight loss. It could be improving A1C. It could be reducing ED visits or hospitalizations. It could just be improving their relationship with food. How can patients navigate through the system? Patients aren't obesity experts. Not very many patients are going to walk in knowing exactly what they need or what they want. And they don't necessarily know where to turn if something is the right fit. So if medications aren't working, they might not necessarily know that it's now time to try bariatric surgery, or it's time to try a different medication, or it's time to reduce or increase your dose. And then scalable, we've really just hit the tip of the iceberg with these medications. Is your workforce ready for the influx of demand, especially since we're getting expanded indications? The medications are getting cheaper. More and more folks are going to end up at the front doors of the health system wanting these medications. We've started to see systems set up triage criteria. Higher acuity patients are going to go to bariatricians or endocrinologists or cardiologists or nephrologists, depending on their specific subset of conditions. Lower acuity patients may do better with a primary care provider, a pharmacist, and somebody that has additional training in obesity. We need to navigate what that looks like and where the right patient needs to go.
One of the things that is important to talk about in managing these patients on GLP-1s for obesity is if they have comorbid conditions and they do have successful weight loss, the other comorbid conditions and medications also need to be managed, because generally you will see an improvement in, let's say, hypertension or hyperlipidemia. That's why it's important high touch that other medications would also have to be adjusted in patients that are taking the GLP-1s and experience a positive weight loss.
We've talked a lot about the positive benefits. One of the things that we're less certain about is long-term effects for the management of obesity. As healthcare providers, we need to be aware or on the lookout for any unexpected adverse events. We assume that patients being treated for obesity and its related comorbidities will be similar to diabetic patients, but we are using higher doses in non-diabetic patients. We just need to be aware and looking for any unknown side effects that may appear with longer-term therapy.
I think that makes a lot of sense.
Well, and considering these currently are thought to be chronic, that if you discontinue them and you regain the weight, we don't have very long experience in trials with people taking these. Given that these may be lifetime medications, we just won't see it, and we've got to keep our eyes out for it.
Right. Could this result in patients almost yo-yoing, losing the weight, going off the medication, gaining the weight, and then going back on the medication, losing the weight again?
Well, and part of the problem with that is with these medications, we're seeing muscle mass being lost and they're not gaining it back. And so if they're yo-yoing it, they're continuing to lose that muscle mass. And so there's some significant concerns. And some of the newer pipeline medications, that's what they're targeting or looking at is, can they find a way to retain the muscle mass, lessen that muscle loss with this medication? That might be a fourth generation type medication.
The last thing is maybe more of a positive direction. The fact that we're seeing all of these expanded indications, we're learning more and more. It seems like something's changing every day for these medications. It's really exciting. And looking to the future, what if we could actually improve the cardiometabolic health of a larger patient population? That's a pie in the sky right now attitude, but it's exciting that we're learning more and more, and there may be possible treatment for these conditions.
Generally, what I've seen that is positive about the GLP-1s is opening up the conversation with obesity. A lot of people are humiliated, didn't seek care before, but it is now a common conversation, maybe a little bit less uncomfortable approaching their healthcare provider or even seeking healthcare, because a lot of people are talking about it. A lot of people are trying to find ways to improve this chronic disease state. And so it's making patients a little bit more comfortable to have the conversations.
It's actually opened up the national conversation as well. Even if you have a patient who says, I don't want to take a GLP-1, it's also opened up the possibility of maybe I need to eat healthier. Maybe I need to incorporate more exercise. Just that alone has been great to hear that being a conversation, because we certainly have an obesity epidemic right now in the United States.
Great. Stacy, Heather, Emily, cannot thank you enough for just sharing your insights with us today. Really enjoyed having you on the podcast.
Thank you.
Thanks.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.